the liver. In this video, we'll cover one of the most important organs in abdominal anatomy. Let's break it down step by step. The liver's structure. As the largest gland in the body, its exact location, shape, size, and color. Detailed breakdown of anatomical and physiological lobes. Segmental anatomy based on Couinaud's classification. Diaphragmatic and visceral surfaces with key impressions and relations. Clinical anatomy, including biopsy landmarks and Porta Hepatis structures. Let's begin. Liver. The liver is the largest gland of the body, occupying much of the right upper part of the abdominal cavity. It consists of both exocrine and endocrine parts. The liver performs a wide range of metabolic activities necessary for homeostasis, nutrition, and immune response. Its main functions are: it secretes bile and stores glycogen. It synthesizes the serum proteins and lipids. It detoxifies blood from endogenous and exogenous substances, examples, toxins, drugs, alcohol, etc., that enter the circulation. It produces hemopoietic cells of all types during fetal life. Location. The liver almost fully occupies the right hypochondrium, upper part of the epigastrium, and part of the left hypochondrium up to the left lateral mid-clavicular line. It lies mostly under cover of the ribs and costal cartilages immediately below the diaphragm. It extends upward under the rib cage as far as the fifth rib anteriorly on the right side, below the right nipple, and left fifth intercostal space anteriorly on the left side, below and medial to the left nipple. In the midline, the upper border lies at the level of the xiphisternal joint. The sharp inferior border crosses the midline at the level of transpyloric plane. Shape, size, and color. Shape. The liver is wedge-shaped and resembles a four-sided pyramid laid on one side with its base directed towards the right and apex directed towards the left. Weight. In males, 1.4 to 1.8 kilograms. In females, 1.2 to 1.4 kilograms. In newborn, 1/18 of the body weight. At birth, 150 grams. Proportional weight. In adult, 1/40 of the body weight. Color. It is red-brown in color. External features. The wedge-shaped liver presents two well-defined surfaces, diaphragmatic and visceral, and one well-defined border, inferior border. The diaphragmatic surface is convex and extensive. It faces upwards, forward to the right, and backwards. The visceral surface is relatively flat and faces inferiorly. These two surfaces meet in front at the sharp inferior border. Conventionally, the diaphragmatic surface is further subdivided into superior, anterior, right lateral, and posterior surfaces. But there is no distinct demarcation between these surfaces. Lobes of the liver. The lobes of the liver are classified into two types: anatomical lobes and physiological, functional lobes. Anatomical lobes. On the diaphragmatic surface, the liver is divided into two lobes, right and left, by the attachment of the falciform ligament. The right lobe, which forms the base of the wedge-shaped liver, is approximately 6 times larger than the left lobe. On the visceral surface, the liver is divided into 4 lobes: right lobe, left lobe, quadrate lobe, and caudate lobe by fissures, and fossae present on this surface. Fissures for ligamentum teres and ligamentum venosum, Porta hepatis, groove of the IVC, and fossa for the gallbladder. These fissures and fossae form an H-shaped figure. Right lobe to right of the fossa for gallbladder. Left lobe to the left of the fissures for ligamentum teres and ligamentum venosum. Quadrate lobe between the fossa for gallbladder and the fissure for ligamentum teres. Below the Porta hepatis, caudate lobe between the groove for IVC and the fissure for ligamentum venosum. Above the Porta hepatis. Physiological lobes, or functional lobes, or true lobes. The division of the liver into lobes is based on the intrahepatic distribution of branches of the bile ducts, hepatic artery, and portal vein. The liver is divided into right and left physiological lobes by an imaginary sagittal plane line, Cantilese plane line. On the postero-inferior surface, this plane passes through the fossa for gallbladder to the groove for IVC. On the antero-superior surface of the liver, this plane passes from the IVC to the cystic. Notch present a little to the right of the falciform ligament. The physiological right and left lobes are approximately equal in size. Each true lobe of the liver has its own primary branch of the hepatic artery and portal vein, and is drained by its own hepatic duct. Segments of the liver. These are structural units of the liver. There are 8 hepatic segments. They are deduced as follows. The right physiological lobe is divided into anterior and posterior parts, and the left physiological lobe into medial and lateral parts. Each of these parts is further divided into upper and lower parts, and form 8 surgically resectable hepatic segments. The veins draining the hepatic segments are intersegmental, that is, they drain more than one segment. On the surface of the liver, there is no identifiable demarcation between anterior and posterior segments of the right lobe. The fissures for ligamentum teres and ligamentum venosum mark the junction between the medial and lateral segments of the left lobe. The caudate and quadrate lobes are incorporated into the upper and lower areas of the medial segment of left lobe. Couinaud segments. According to Nomenclature of Couinaud, the hepatic segments are numbered 1 to 8, 1 to 4 in the left hemiliver, and a 5 to 8 in the right hemiliver. According to this nomenclature, the segment 1 corresponds to the caudate lobe, and segment 4 corresponds to the quadrate lobe. Segment 1 to 4 of the left lobes are supplied by the left branch of hepatic artery, left branch of portal vein, and drained by left hepatic duct. The segments 5 to 8 of right lobe are supplied by right hepatic artery, right branch of portal vein, and drained by right hepatic duct. A large volume of liver, 80%, can be removed safely because healthy hepatocytes have great capacity of regeneration. The liver can regrow to its original size within 6 to 12 months. Diaphragmatic surface, superior surface. The convex right and left parts of this surface fit into the corresponding domes of the diaphragm, which separate them from the corresponding lung and pleura. The central depressed area of this surface is related to the central tendon of the diaphragm, which separates it from the pericardium of the heart. Hence, this area is often termed cardiac impression. Anterior surface. It is related to the xiphoid process, an anterior abdominal wall in the median plane and diaphragm on each side. The falciform ligament is attached to this surface, a little to the right of the median plane. Right lateral surface. It is related to the diaphragm, opposite 7th to 11th ribs in the mid-axillary line. Through the diaphragm. Upper 1/3 of this surface is related to both the lung and the pleura. Remember, the lung extends up to the 8th rib. 1/3 of this surface is related to the custodiaphragmatic recess of pleura. Remember, the pleura extends up to the 10th rib. Lower 1/3 of this surface is related to 10th and 11th ribs. Example, it is related neither to the lung nor to the pleura. For taking biopsy of the liver, the needle is inserted in the mid-axillary line in 9th or 10th intercostal space to avoid injury to the lung. Posterior surface. This surface presents bare area of the liver, groove for IVC, caudate lobe, fissure for ligamentum venosum, and posterior surface of the left lobe. The bare area of the liver is a triangular area to the right of groove for the IVC between the 2 layers of coronary and right triangular ligaments. It is in direct contact with the diaphragm. The right suprarenal gland is related to the inferomedial part of this area, that is, near the groove for IVC. The groove for IVC, as the name indicates, lodges the IVC. Its floor is pierced by the hepatic veins. The caudate lobe presents 2 processes: a papillary process, which arises from its left side, and a caudate process above the Porta Hepatis, which connects it to the rest of the liver. The fissure for ligamentum venosum is a deep cleft to the left of the caudate lobe. The ligamentum venosum lies in its floor. The posterior surface of the left lobe is related to the abdominal part of the esophagus, just to the left of the upper part of fissure for ligamentum venosum, and causes esophageal impression. The fundus of the stomach is related just to the left of the esophageal impression. Visceral surface, the inferior surface of the left lobe, is related to the anterosuperior surface of the stomach, which produces a gastric impression. Near the left side of the fissure for ligamentum venosum, the fissure for ligamentum teres is a deep cleft to the left of the quadrate lobe. The ligamentum teres lies in its floor. The inferior surface of the right lobe presents 3 prominent features: quadrate lobe, fossa for gallbladder, and Porta Hepatis. The relations of the inferior surface are: the quadrate lobe is related to the pyloric end of the stomach and the first part of the duodenum. The fossa for gallbladder lies to the right of the quadrate lobe, occupied by the gallbladder, with its cystic duct close to the right end of the Porta Hepatis. The right colic flexure is related to the inferior surface to the right of the gallbladder, near the inferior margin, and produces colic impression. The junction of first and second parts of the duodenum is related to the right upper part of the fossa for gallbladder, an adjoining part of the right lobe, and produces the duodenal impression. The right kidney is related to the inferior surface, posterior to the colic impression and to the right of the duodenal impression, and causes renal impression. Porta hepatis, gateway of the liver, is a horizontal fissure on the inferior surface of the liver between the quadrate lobe and the caudate lobe. The main structures entering the porta hepatis are right and left branches of the hepatic artery and portal vein, and the main structures leaving the porta hepatis are right and left hepatic ducts. They lie in the order from posterior to anterior as vein, artery, and duct. EAD. Also present in the porta hepatis are lymph nodes and nerves of the liver. Thanks for watching. Like, share, and subscribe for more medical content. If you have any topic requests, drop them in the comments below.